liver problem. And the last one, we had a gastrointestinal bleeding, which was very nicely attended, and we discussed the pharmacotherapy in GI bleed, and we had endoscopic management. And this is the fourth in the series where we have a very interesting, actually, topic, which is renal failure in patients with liver diseases. This is something which I think all internists, medicine people, fellows, residents, PG students, and across specialties, you come across this problem. Patients have liver problems, and you have, been called to see because he's got renal failure. And also, we as hepatologists and gastroenterologists, this is almost like a bread and butter of our study, of our, day-to-day care. And many times in my ward rounds and ICU rounds, I feel that 50% of my discussion in the rounds has been on renal failure, actually. We keep on talking about kidney. And it's really, I think, absolutely important that every hepatologist, gastroenterologist should have deep knowledge of renal hemodynamics, renal pathologies. And I think every internist, every medicine person, whatever specialty you are, you must have a thorough grasp on the renal issues. So I thought today we'll have two very interesting talks. And for this, the first one, we invited Gagan Chabbra, a senior consultant nephrology and renal transplantation. And being a nephrologist himself, I thought it would be a very, very right thing for us to have a nephrologist speak to us on the various renal issues. How do we assess the renal issues in patients with liver diseases? Especially this would be something which is as a starting point, and following this we will have a talk by Dr. Rakhi Maiwal on HRS, which we will have a in-depth introduction after this. And as the format would be, we would have both the talks one after other, and then we'll have a set of questions. And I would request all of you attendees, please note your questions, and you can post them in the chat box as the lectures go on, and so that we can compile, and we will request both the speakers and myself to give you meaningful answers to your queries. And with that, it is again my really proud privilege to invite Dr. Gagan, a dear friend of mine, to speak on assessment of renal dysfunction in patients with liver diseases. So Gagan, over to you.
Thanks a lot to the whole liver team, and especially to you, Dr. Saigal. I hope I live up to the expectations. So the talk is very interesting indeed. Assessment of renal dysfunction in patients with liver disease. And the topic, however it sounds easy, is not that easy too. So coming to the first of the slides. So renal and liver dysfunction often present together. So it's a combination that happens most of the times. So it can be either due to a multi-organ involvement in acute illness, or it can be due to a secondary advanced liver disease that the kidney gets involved. And whatever the point is, the renal impairment in both the groups is a poor prognosticating indicator. So we are looking to a bad prognosis if we have two major organs involved simultaneously. So it can be simultaneous liver and kidney involvement. It can be primarily liver with a secondary kidney involvement. It can be primarily kidney with a secondary liver involvement. So renal hyperperfusion is the central pathogenic mechanism due either to a reduced perfusion pressure or increased renal vascular resistance. We will discuss them in detail. Now, renal failure is a frequent complication of patients with liver cirrhosis, and it has a very high mortality and morbidity, occurring in around 1 of every 5 patients with cirrhosis. The incidence of renal failure in acute liver failure varies from 40% to 85% depending upon the etiology. So it's both the acute liver failure as well as the chronic liver disease which gets the liver involved. Acute renal failure in patients with cirrhosis, particularly with advanced liver disease, seems to be common. However, the exact incidence is probably underestimated. So patients with cirrhotic tend to have falsely low serum creatinine levels. We must remember that, especially for the students. And this may be due to a decreased hepatic creatinine synthesis and also a decreased skeletal mass of these patients. Now, the probability of occurrence of hepatorenal syndrome in patients with cirrhosis and ascites at 1 year and 5 years is from 18% to 39%, with the mortality approaching as high as 100% in type 1 HRS without specific therapy. So this has a real bad mortality. So these are the various factors, and the interaction of these factors is what is important. So we have changes in the systemic arterial circulation, we have a portal hypertension sitting underlying, then we have activation of the vasoconstrictors, and we have a suppression of vasodilator factors acting on the renal circulation. So all these interactions is probably what is behind this complex phenomena of renal dysfunction in patients with chronic liver disease. The pathophysiology of functional failure in ALF is similar to that in cirrhosis. So the pathophysiology in acute and chronic are more likely similar. With patients of ALF may develop portal hypertension, but to a lesser degree than those with the frank cirrhosis. So moving further, increased release of endogenous vasodilators, especially nitric oxide, which escapes from the splanchnic to the systemic circulation through portosystemic shunts occurs. Then, secondary to that, there is a development of intense systemic arterial vasodilatation. This vasodilatation leads to reduction in the systemic vascular resistance, and that leads to a high cardiac output and a hyperdynamic circulation. Now, this increased cardiac output may be inadequate to compensate for the drop in the vascular resistance, systemic vascular resistance. That results in hypotension with a mean arterial pressure commonly falling to around 60 to 70 millimeter of mercury. If we remember that in a healthy individual, there is autoregulation which occurs in the kidneys. So if the blood pressure falls, a person is healthy, it can autoregulate. Healthy means not with so many comorbidities. So there can be an autoregulation to maintain the perfusion pressure up to a particular level. But in these patients, the autoregulation may be deficit, absent, or malfunctioning. So altered renal vascular autoregulation, as seen in sepsis, may also be present in hyperdynamic circulatory failure of acute liver failure. This making this renal blood flow directly dependent on the blood pressure. So now this decreased renal blood flow is depending upon a blood pressure rather than a help getting from an autoregulation of the renal function. So in some patients with cirrhosis, especially in colics, there's also an underlying cardiomyopathy and a heart failure, which may further complicate this process. So the normal hemostatic response to vasodilatation is activation of several neurohormonal mechanisms, such as the RAS activation, sympathetic nervous system activation, arginine vasopressin increase. And this activation leads to intense vasoconstriction and retention of salt and water, leading to more of ascitic development, overload of the fluid. This is done to maintain a blood pressure for the perfusion of the vital organs. There are other vasoconstrictors which are also involved. So the renal blood flow is kept within the normal limits in the early stage of the renal disease when the patient is getting a compensated type of a phenomena going on, due to the release of certain local vasodilators such as prostaglandins. Once this compensation goes into a jeopardy, this can be due to various reasons. There can be various triggers for this compensation to go into a jeopardy. In situations such as circulatory volume loss, some cases of gastrointestinal hemorrhage, there can be renal hyperperfusion, and subsequently prerenal type of azotemia may occur. But this is a prerenal type of azotemia leading because of a circulation loss. Then there may be a progression of the liver disease also, and there leads to extreme vasoconstriction due to the compensatory mechanisms of the vascular bed that predisposes the kidney to the development of a more complex hepatorenal syndrome rather than just a prerenal involvement. So the thing is, the continuing vasoconstriction and renal vascular resistance results in contraction of the mesangium. Mesangium is the part of the kidney, and then with reduction in the glomerular surface area, and these two phenomena combined leads to an acute tubular necrosis. Now, there is something more important happening along with this. What is that important part? The mechanism of inflammation is the important part. Bacterial translocation from the intestinal lumen to the abdominal lymph nodes may occur in patients with advanced cirrhosis. This oral liver failure patient, this leads to increased circulating level of lipopolysaccharides, binding protein, and tumor necrosis factor. which causes splanchnic vasodilatation and renal vasoconstriction, and this secondarily leading to hepatorenal syndrome or a renal dysfunction, renal failure. Now, earlier it was not considered it was considered exclusion criteria. Now it's one of the most important things in patients with hepatorenal syndrome. That is, spontaneous bacterial infection is one of the most common triggers of HRS-AKI. HRS is not only influenced by hyperdynamic alterations, but also caused by systemic pro-inflammatory process due to pathological bacterial translocation in advanced cirrhosis. So, the phenomena of inflammation plays a very important role here in precipitation of the renal function in patients with the liver disease. The patient with decompensated cirrhosis show increased level of cytokines, which show the underlying inflammation going on. Now, this cartoon is in a nutshell is explaining the same thing which I have done in the last few slides. We have a cirrhosis with portal hypertension. We have splanchnic vasodilatation and decreased effective arterial volume. Now, this effective decrease in arterial volume, which leads to increased cardiac output and type of a hyperdynamic circulation, which sometimes restores the balance. And then secondarily, there is also activation of some vasoconstrictor things like RAS, like secretion of ADH, sympathetic nervous system activation, leading to sodium and water retention, leading to development of ascites, fluid overload, as well as extrasplanchnic vasoconstriction, leading to hypoperfusion and leading to the injury. Now, this injury may be precipitated by sepsis, may be precipitated by GI bleeding, may be precipitated by the hypotension, may be precipitated by the drugs. And along with that, also plays a part is the cirrhotic cardiomyopathy. This excellent figure also shows the same thing. This is cirrhosis with portal hypertension with vasodilatation theory, which I have explained. Then there's the inflammatory theory, which goes simultaneously, and this is somehow compensated. This leads to a high cardiac output, some ascites, increased kidney susceptibility to ischemia, but a normal GFR. Once these things get severe, the cirrhosis get advanced, the other things get more severe, then there is a low to normal cardiac output, ascites increases, and the GFR may decrease. Acute kidney injury may precipitate because of more arterial vasoconstriction, more inflammation taking part, more microvascular changes, and damage to the autoregulation of the kidney. So that what actually leads to precipitation of acute kidney injury in patient with liver disease, or a renal dysfunction, I should say, in a patient with liver disease. Now, this slide I have just included to explain that renal biopsy in a patient with HRS and renal biopsy in a patient with ATN. Now, HRS also will show normal glomeruli. There are two glomeruli seen in this biopsy, and both of them appear totally normal. And the tubules here you see, they show some dilatation and some widening of the lumens. That's an injury. And there's a thinning of the tubular epithelial cells. You can see here dilated tubes. I have encircled them. They are showing some dilatation. There's an acute tubular injury. Now, moving further, if there's a sloughing inside, which is shown by the arrow now, you see there's a total damage to the tubule leading to acute tubular necrosis now rather than a tubular injury. But clinically, if you ask me, it's very difficult to differentiate HRS, ATN on a biopsy. The cause of it means HRS may, acute tubular injury may be there. It may be due to an intrinsic cause of renal failure, or it may be because of the HRS. So it's very difficult to differentiate by biopsy. It's not easy. So this is a diagnostic criteria of renal dysfunction and cirrhosis. We have an acute kidney injury, a rise in serum creatinine to greater than 50% of the baseline, or a rise of greater than 0.3 milligram per deciliter in less than 48 hours. Then we have a chronic kidney disease sitting aside. 3 months is the golden period. Any GFR less than 60 for greater than 3 months puts it into a chronicity. That's a chronic kidney disease. Now, when we combine the two definitions, acute kidney with the chronic, then we have an acute chronic kidney disease, which makes that matter more difficult. So, there are different types of renal dysfunction which can occur in patients with cirrhosis. It can be pre-renal that I have discussed. The most common cause of AKI is pre-renal, which occurs in approximately 70% of all cases. Then there's the intrarenal. The main cause of intrarenal AKI is acute tubular necrosis. We have seen the slide. Then there's a post-renal, which is a very rare cause of renal dysfunction, less than 1%. And then, of course, HRS, that is hepatorenal syndrome. In this, one of the studies you have mentioned here, 152 patients with cirrhosis showed 70% of patients had acute kidney injury, 17% had AKI, with a chronic kidney disease and 13% had underlying chronic kidney disease. So it is very, very important to mention here that it is to differentiate between acute and chronic is as important as to differentiate between causes of the various acute kidney injuries in patient of the liver disease, because that is important from the prognostication point of view as we move further. So CKD, the arrow goes here, AKI, the arrow goes here, and then we have HRS, hepatorenal syndrome, within as a part of AKI and an ATN meeting each other, creating more confusion than the usual. So you have to differentiate between these various factors. So pre-renal, patients with advanced renal disease are susceptible to pre-renal azotemia, secondary to the development of relative hypovolemia and reduced effective central blood volume. Then we have the intrinsic renal disease that may be due to certain drugs, toxins and infections. The disease which is mainly due to drug, toxin infections mainly present is as tubular interstitial in nature and acute renal dysfunction. And that may also be a part of a chronic liver disease, which may later present as glomerulopathy and is more stable type of a chronic kidney disease along with the underlying chronic liver disease. So intrinsic disease can be acute, intrinsic disease can lead to chronic stable kidney disease, which may have an underlying glomerulopathy. That's the glomerular cause of the kidney disease. This chart will further explain that, this table. We have a tubular interstitial involvement due to drugs, due to toxins, due to infections, due to some reactions. Then we have a glomerular involvement. It may be due to drugs, that may be due to infection of hepatitis ABC, that may be due to type 2 mixed glomerulinemia, that may be due to IgA nephropathy underlying, and that may be due to other associated diseases like sickle cell disease. Then we have some systemic disorders which may have both the involvements of the kidney and the liver, like vasculitis, toxemia of pregnancy, and the health syndromes. So these diseases need to be differentiated. Now we have hepatorenal syndrome. It's a functional renal failure, as used to be defined as, often complicates advanced liver disease, hepatic failure, or portal hypertension. The incidence I have already told you, and this what happens, and this is an intense intrarenal vasoconstriction in the presence of vasodilatation of the systemic and splanchnic circulation, which we had discussed in our pathophysiology slides, that the splanchnic circulation is dilated, but the internal vasoconstriction is occurring. So there's a decrease in effective systemic circulatory volume despite an overall expanded total extracellular volume. So this is very important to note that effective circulatory volume is less in spite of an overall total extracellular fluid volume, which is very, very important. So moving further, traditionally HRS used to be classified as type 1, which was the more fulminant type of HRS, rapidly progressive, defined as either doubling of the initial serum creatinine to greater than 2.5 or a 50% reduction in GFR to less than 20 ml per minute over a 2-week period. So this was more fulminant type of HRS. It had oliguria, encephalopathy, hyperbilirubinemia, and a very poor prognosis and a high death rate within a month after presentation. Then there's a more subtle type of HRS, which is known as type 2 HRS. It is characterized by more benign course, stable reduction in GFR over a period of weeks to months. The pathogenesis is incompletely understood, but it's more likely to be the same, involving the vasodilators and the vasoconstrictors. And what diagnosis is dependent only on exclusion and mainly on the creatinine levels. So that's why there's a lot of confusion to differentiate a type 2 HRS from underlying other causes of the renal dysfunction. So this is a very good 2 tables, used to be traditionally considered as one of the more important tables. But ask me, it is clinical things are more important rather than these just definitions and lines. So what was important in this table? Initially, there was a major criteria and a minor criteria as a diagnostic criteria for hepatorenal syndrome. And if you see the point number 3 here, there was exclusion of shock, ongoing bacterial infection, volume depletion, and use of nephrotoxic drugs. So they used to exclude bacterial infection. If there's a bacterial infection, HRS has to be excluded, but it's not now like that. So bacterial infection may act as a trigger and may precipitate HRS and may be present along with associated HRS. Other criteria we all know, urine volume, which is a minor criteria, urine volume less than 500 milliliter per day, urine sodium less than 10, osmolality greater than plasma. So I'm not going to detail. But what is more important, as you may have read in your PG books also, is the differentiation between a pre-renal, intrinsic renal, and a hepatorenal syndrome. Now, if you see closely, what is most important here is the urine indices. Urinary sodium less than 10 in both hepatorenal as well as pre-renal, but more than 30 in intrinsic renal. Then According to me, what is more important is the urinary sediment. You see a prerenal failure presenting with a normal urinary sediment and an intrinsic renal failure presenting with scarce cellular debris and hepatorenal failure presenting with an unremarkable urinary sediment. So what is more important is the urinary sediment, a good history of the disease, okay, a clinical course to see the response of a fluid challenge and an ultrasound to exclude the other causes and to see the elevated resisting index. So these are the important criteria and the clinical criteria to differentiate between the various causes of renal dysfunction in patients of liver disease. Taking further, this is the newer definition of acute kidney injury as per International Club of Ascites. Now this stages into three types of acute kidney injury. Stage is 3. Important is stage 1, in which the increase in creatinine is 0.3 gram per deciliter or increase of serum creatinine to greater than 1.5 to 2-fold from the baseline. Now, if the total increase is less than 1.5, it is classified as 1A. If it is more than 1.5, it is classified as 1B stage. But if the increase of the creatinine is more than 2 to 3-fold of the baseline, then it is stage 2. And if the increase is more than 3-fold of the baseline, then it is stage 3. Or you have a patient on the renal replacement therapy. That means a patient on dialysis. So that becomes stage 3. Now, this is the current criteria for HRS-AKI according to the ICA consensus, in which we have a liver cirrhosis with ascites. We have a diagnosis of AKI, especially depending upon the serum creatinine. We have no response to diuretic withdrawal. We have no response to plasma volume expansion. We have no nephrotoxic drug. We have no proteinuria or less proteinuria, you may say. We have no microhematuria, and we have no pathological ultrasonography, means a normal ultrasound of the kidneys. So this is how we compare the old with the new. The old type 1 HRS and type 2 HRS has been now classified in a better way, which makes it more easy for us to define and classify. It is now HRS with acute kidney injury and HRS with chronic kidney disease. Now, HRS with acute kidney injury is increase in creatinine within the 48 hours, greater than 0.3 as we have discussed, or a 50% greater increase from the baseline within less than 3 months. So 3 months is the magical figure again. Less than 3 months, if the increase is more than 50% of the baseline, you fit it into acute kidney injury. Now, if the same increase or the GFR drop is in greater than 3 months, and the GFR is less than 60 ml per minute by MDRD, then you fit it into chronic. But what is more important is to differentiate this hepatorenal syndrome, CKD, vis-a-vis a chronic kidney disease separately sitting inside. So a patient may be having a chronic kidney disease due to some structural abnormality, some glomerulopathy, some intrinsic kidney disease, which may not be HRS-CKD. Your patient may be having hepatorenal syndrome with a chronic kidney disease because of HRS, that is HRS-CKD. So it is very, very important to differentiate these two factors also. Now this shows, a small chart in a flow chart is taken from this paper review article. The AKI stage 1B responding to withdrawal of diuretics to fluid challenge. If this doesn't respond, probably fitting into HRS-AKI, will require vasoconstrictors and albumin. Our next speaker will discuss this management of HRS, so I'm not going into that. What I'm going into is the response of stage 1A is faster than the response of stage 1B. In 1A, we require monitoring, we require withdrawal of the nephrotoxic drugs, we require withdrawal of the factors which precipitated the AKI. So what is important is the clinical history. That's why a clinical history and a good urine examination is very, very important for a clinical assessment of renal dysfunction in patient with liver disease. So if you know the factor which has precipitated the AKI, if you withdraw that factor, then probably the AKI gets resolved. So it's a resolution, there's a stability, and there's a progression. If there's a progression, then you see for hepatorenal component of involvement. But if there's a resolution, then we don't need to see for HRS component involvement. Then we can differentiate between the various types of renal dysfunction in patients of liver disease. So this also is a very simple slide. History taking, which sums up physical examination, urine analysis, urine sodium, infection workup, and renal ultrasound. These are very important to differentiate for clinical assessment. Then we have a post-renal, which is like negligible. Then we have a pre-renal, which will either respond to the volume, most of the cases, and will get resolved. Then we have a hepatorenal syndrome, which will not respond to that, but will respond to albumin, vasoconstrictors. If this responds, well and good, doesn't respond, may require a liver transplant isolated or a combined transplant, or a TIPS or a RRT as a bridge up. And the third one is the intrinsic renal factors, which is 30% of the factors, in which you see for the renal disease, you do a kidney biopsy if you can, and see for the etiology of that factors. So moving further, now something new. Is there anything new in the pipeline? Because creatinine is not a very good marker. As we all know, this creatinine remains low in patient of chronic kidney disease. The rise may not be that much. The disease may be more significant than what the creatinine value is already showing. So there needs to be some new markers. And we have some papers, some studies going into new markers, especially new kidney biomarkers in urine in patients with acute kidney injury and cirrhosis. We have NGAL, we have KIM1, we have IL-18, we have LFAP, and we have albumin. Now, these markers can be either showing a tubular marker, means showing a tubular damage, or a glomerular marker showing a glomerular damage. So, the tubular markers are the NGAL, IL-18, KIM1, and LFAP. So we have a tubular component of the kidney, and these are the markers which are created from that component. So these are the markers which show tubular injury. So more likely to be something like a pre-renal, hepatorenal type, differentiating between the two. And then comes the glomerular marker, which is the traditional and time-tested glomerular marker, that is albuminuria. That is why accounting for amount of urine albuminuria is very important to see for the underlying chronic kidney disease or underlying intrinsic renal disease or underlying glomerular injury. So albuminuria is a good marker for glomerular injuries. So NGAL is a glycoprotein which could help to determine the cause of AKI in cirrhosis. It is overexpressed in kidney by impaired kidney epithelia. So what happens? NGAL level in urine rises exponentially as well as earlier than the serum creatinine during an AKI. NGAL levels are much higher in patients with ATN than those with patients of AKI with pre-renal and hypovolume-induced AKI. So what is happening here is we are trying to use this urinary NGAL to differentiate between ATN as a cause of renal injury or a HRS or a pre-renal part as a cause of renal injury. So NGAL levels in patients with hypovolemia-induced AKI is similar to the NGAL levels in patients without AKI. So NGAL will be found to be high more in the patients with ATN. But you have to be careful. These two have its limitations. The NGAL level also is in patients with urinary tract infections because of production of L-GAN in leukocytes. So level could be falsely positive during urinary tract infections. Yeah, so this is the other marker, IL-18. Biomarker is similar to urinary L-GAN. That also increases in patients with ATN and is found to be okay or relatively less in patients with hypovolemia-induced AKI or HRS. This is the paper which has shown the importance of these markers. This is a study. The most important markers here were found to be NGAL. Then there were other markers like glutathione S, TFF3, that is trefoil factor 3. We have IL-18, we have albumin. These are the various markers that were studied. NGAL was found to be the most effective of these markers. And a number of biomarkers appear promising for differential diagnosis between ATN and other types of AKI. That's what was the conclusion of the study. The most interesting biomarkers were for ACLF and prognosis are NGAL, osteopontin, albumin, and TFF3. So these results support the role of major inflammatory reactions in the presence of ACLF. That again shows inflammation is involved in the patients in the underlying pathophysiology of HRS. So these novel biomarkers have the advantage that they can differentiate within the types of the AKI that we are having, and this differentiation will lead us to prognostication. How can we prognosticate the patient and the family regarding the outcome of the disease? Then there are the shortcomings because there is no correlation with the kidney biopsy that has been shown or done. Then there may be an overlap between two types of AKI. This is the most difficult part when the two AKI parts are going simultaneously. Something going underlying already a chronic kidney disease process sitting inside, overlapping, there's a HRS syndrome. It becomes more difficult to gauge the role of these markers in such a type of setup. And further studies are required before we can admit straight away that these markers give exact idea of what is happening inside the kidney at the time of liver disease. So what are the salient points? Arterial hypertension, which is an unexpected finding in patients with cirrhosis, less glomerulonephritis. So if a patient has a hypertension, then you should look for the cause of that, especially a cirrhotic patient, that there's and proteinuria, then you should look for a glomerular cause of that disease, for the kidney disease. The course of renal response to fluid challenge and vasoconstrictor therapy can also help differentiate the cause of acute azotemia and liver disease. Renal improvement, renal function denotes pre-renal failure. So improvement, if it is rapid, shows more likely to be a pre-renal cause. If the improvement is slow or delayed or no improvement, then it is more likely to be ATN and HRS. If the improvement occurs because of restrictions, it is more likely to be because of HRS rather than because of ATN. So this is another last slide, second last slide, just to show that in case you require a combined kidney liver transplant, these are the factors we consider. Disease, end-stage disease on dialysis, more than 3 months of chronicity, biopsy shows chronicity, and this last factor, which has been modified now, and duration is still debatable. That is acute kidney injury with creatinine greater than 2 and requiring dialysis for greater than 8 weeks. So, a take-home message in the nutshell: renal dysfunction and liver failure go hand in hand. A good history, a good clinical examination, supported by the labs, can clinch diagnosis for us. And this is one of my favorite slides. And Swami Vivekananda quoted, "Never say no, never say I cannot, for you are infinite. All the power is within you, you can do anything." Thanks a lot. Thank you very much for the patient hearing.
Right. Thank you, Dr. Gagan. That was a very nice and very lucid talk, and you did, mention a lot of things which are, important to understand the renal issues in patients with liver problems. I'm sure there would be a lot of practical questions which we can ask you later on, and I think it will be probably right to move on to the next talk and then come to the questions. Gagan, is that okay for you?
Yeah, right. Yes, sir. I'm totally fine with it.
Right. So I would now invite Dr. Rakhi Maiwal. She is the additional professor, Department of Hepatology at the Institute of Liver and Biliary Sciences. She has a very keen interest on ICU care of liver patients who have got renal failure. She has done a lot of work, a lot of publications, and I think that she would be really the right person to speak on management of hepatorenal syndrome, the practice. But I will try and tell her that do cover the basics because we have a lot of PG students and all, and it will be really a delight to listen to Dr. Rakhi. Rakhi, please, over to you. Thank you.
Thank you, sir, and thank you so much for this invitation. And I would like to thank Dr. Vinita and Dr. Saigal for inviting me and for this very important talk about management of hepatorenal syndrome. My work has been made very easy by the wonderful talk by Dr. Gagan. So this is going to be the outline of my talk. I'll talk about I will very quickly go through the definitions and the pathophysiologic basis because that has been nicely covered. And we'll focus on the management, the challenges that we have while managing these sick patients and how do we go about it. So what I thought was, because the talk was about current concepts and very recently the concept of inflammation or infection-driven HRS, how do we diagnose, how do we use the biomarkers, and how do we manage these patients? So therefore, I chose this case of acute on chronic liver failure, a 39 years old gentleman. So what we'll do is we'll go over the case and we'll keep on discussing how we go about assessment and management. So this gentleman was a resident of Mizoram. He was a diagnosed case of portal hypertension, had grade 2 esophageal varices outside after he developed an acute onset of jaundice, which was related to alcoholic hepatitis. His last intake of alcohol was 3 months back. He came to us with the jaundice, ascites followed by decreased urine output and breathlessness. So this patient had a high SOFA score. His ARC score was 12. The patient was already admitted in an outside hospital and he had taken LAMA and had come here. So when we saw this patient, he was received in the emergency department. He was conscious and oriented, but he was afebrile. He was having a hypertension, and there was the respiratory rate and the tachycardia was present. This patient was icteric. He had tense ascites, his intra-abdominal pressure, which was subsequently measured after coming into the ICU. And we do that routinely for all these patients, was 18 centimeters. He was non-oliguric, but he had AKI. He was breathless, and we can see here the focus of infection was, sorry, I think so. So the infection focus was found to be pneumonia. The ascitic fluid had ruled out SBP. And we can see here the labs. This patient had a preserved pH, and he had a PF ratio around 197. The leukocyte counts was high, and so was the NLR. His INR was 7.1. His creatinine was 2.2. Bicarbonate of 15. Ammonia was 177. So this patient, subsequently, we did an echo, which was normal. And this patient had a stage 3 AKI. He was non-oliguric, which was complicated with metabolic acidosis. He had hypophosphatemia, hyperuricemia, hyperammonemia, and encephalopathy we thought was multifactorial. And we can see, we will discuss in this particular patient the case of a AKI stage 3 in a patient who has acute and chronic liver failure, possibly an infection and inflammation driven AKI, which is non-oliguric, not looking like ATN, but we'll see how we diagnose and manage this case. So the definition of AKI has evolved over the period of years, and we have moved from taking off the absolute value of serum creatinine from the diagnostic criteria. And what is very, very recent is applying the urine output criteria. Now, previously, the hepatologist had ruled out the incorporation of urine output because we felt that urine output is not reliable, particularly because all these patients are on diuretics. You're not catheterizing your patients, so there is no point in measuring the urine output in these patients. However, when you're managing your patients of liver disease in the intensive care unit, their urine output is very, very reliable. And you can diagnose AKI early because in that particular setting, your serum creatinine may not be reliable because most of these patients are deeply jaundiced and they have volume problems, and therefore creatinine may not be reliable. And very recently, the diagnostic criteria, again, I'll not go into the details, but this is the previous criteria and which has been again evolved to exclude out the value of serum creatinine. And it is about when you have to diagnose hepatorenal syndrome, you have to give an appropriate volume expansion for about 48 hours. And what is recommended is that you have to give albumin infusion, 1 grams per kg. There should not be any shock. So in our patient, there was shock, and the shock is has not to be there for the diagnosis of hepatorenal syndrome, because most often your patients with shock will have acute tubular necrosis. And again, you have to rule out structural causes of AKI, intrinsic causes, and you have to rule out the insults which can cause acute tubular necrosis for the appropriate diagnosis. And this has been nicely covered. And these are the revised diagnostic criteria. So HRS2 is now called as HRS-N-AKI. And what we'll be doing is focusing on the management of HRS-AKI and not NAKI, because that's not an emergency, that's not a problem. That's a slow and indolent form of renal dysfunction. So we'll focus on HRS-AKI management. Now, this is about what Dr. Gagan was also talking about, is that when you're managing your patients of liver disease, AKI can happen because of liver failure alone, or the patients may have organ failure or circulatory dysfunction, inflammation, infections can drive AKI. So this is the data from our ICU of 291 patients, 58% had AKI presentation. And what was important here was at day 7, we found that almost half of these patients had either a progressive AKI or AKI which was not resolving. And this progression or persistence of AKI, despite therapeutic management or interventions was associated with worse outcomes. And that is why AKI management becomes very, very important, because it also influences the prognosis of these patients. And what we found here was what governs this progression or persistence is the presence of systemic inflammation, the infections due to drug-resistant or multi-drug-resistant bacteria. And I know all of us are handling these infections, and these are very difficult to treat, require nephrotoxic drugs, and therefore the kidneys become a challenge to manage. Elevated serum bilirubin, like in our patient, and the number of extrahepatic organ failures. These were the important other components that become very, very relevant while you're managing your patients in the intensive care unit. Now, the other very important part of this study was that we showed in a prospective, this is the first and the only study, which is a prospective cohort study. And we showed that urine output over here, these are the progressors and the persistent patients who had AKI day 7, the urine output was preceding changes in the elevation of serum creatinine. So if you're managing your patient of liver in the ICU, it is better to go with urine output, look at the blood gas parameters, and don't wait for the serum creatinine, because serum creatinine is not very reliable. Now, the pathophysiologic basis, I'll not go into the details, and these are all the factors which have been nicely covered. And what is important in case of acute on chronic liver failure, we have to also look at some other important factors, particularly inflammation, sepsis, the cytokine storm, the endothelial dysfunction, coagulation disturbance, microcirculatory dysfunction, and particularly the toxic injury due to bile acids and the bilirubin, because these are patients which are deeply jaundiced. So all these factors also come into the play, apart from the portal hypertension that is driving the HRS development or the kidney injury in these patients. So we go on to the management algorithm, and we know that liver transplant is the best solution for management of hepatorenal syndrome. But what has been clearly shown is that if you transplant your patient with hepatorenal syndrome, the survival is definitely better in patients who achieve a reversal of the HRS. So it's very, very important that we achieve a reversal of the syndrome with the help of medical management. And this algorithm also was shown. And what we need to remember here is this is the most simplest of its own kind of algorithm. But when we see patients of liver, we see patients with ACLF, like I showed, where you cannot wait for 2 days. You cannot give 1 gram per kg albumin to all patients if they are in stage 3 at a severe end with pneumonia. Can we give this amount of albumin? No. So we have to have an individualized approach, whether we should be using albumin alone or we should be using crystalloids, what is the type and the volume, what should be the timelines. If you're going by urine output, should we wait for the serum creatinine for 48 hours for the diagnosis of HRS? And how do we manage patients with acute tubular necrosis? All that is not there in this algorithm. So we'll discuss how we manage these patients. So when we talk about fluid management, because hepatorenal syndrome, you have to diagnose only after an appropriate volume expansion. And what can be the choice of fluid for these patients of AKI? We have 5% or a 20% albumin. We also have 25% albumin, which we are using. It's quite good for patients who are volume overloaded. Then you have the choice for crystalloids. It could be balanced crystalloids or normal saline. You may use a combination of albumin and the crystalloids, and you have to go by dynamic indices. I do not have any data to show you here, but this is what is now recommended, and this is the data which we can extrapolate from non-cirrhotics, that we should go by fluid responsiveness. So we should individualize and do not give a protocol-based approach for the fluid management for all our liver patients presenting with the AKI. And the targets remain, we target the mean arterial pressure, urine output, and if you're in the intensive care, you can see the lactate measurements. Now, previous randomized controlled trials, these are all landmark trials done in patients with chronic liver disease who had hepatorenal syndrome. They had clearly shown that albumin is supposedly a superior as compared, along with the vasoconstrictor, is superior as compared to vasoconstrictors given alone for the management of hepatorenal syndrome. So after you've done an appropriate volume expansion and your patient has had a diagnosis of hepatorenal syndrome, then also you have to go with the combination of vasoconstrictors, and albumin is superior here. And this has been nicely studied in this animal model study by Paolo Angeli and their group, where they compared 3 different volume expanders, the saline group, the another colloid, the synthetic colloid here, and compared to albumin. And what was shown in these cirrhotic rats was that albumin was working by improving the cardiac function. So cardiac function was shown to improve in these cirrhotic animals who had ascites. And that's how we can extrapolate this data in patients with hepatorenal syndrome. And they also showed in these animals that there was inflammation, as was seen by the upregulation of the NF-kappa B and the INOS, and this was downregulated. So albumin has multimodality functions in patients with hepatorenal syndrome and therefore remains the fluid of choice. Now, what about patients who have some degree of septic shock and have infections? So in this particular condition, you have the choice, and this is our own data, and this paper has been accepted, where we show that a balanced crystalloid like plasma light is a much safer modality if your patient has AKI in context of pneumonia, because the complications are more with 20% albumin, a higher discontinuation when rapidly infused. So that 1 gram per kg again may not be reliable in patients with pneumonia and patients with shock where you have some degree of hepatorenal syndrome. And similar data was shown in this entire group of investigators, where they were targeting in patients with hospitalized patients with chronic liver disease, and they gave 20% albumin for improvement of kidney dysfunction, infections, and they found that even though there was no difference in the survival, however, the chances of pulmonary complications was much higher in 20% albumin. So we need to be very careful. Now, we don't have data, but again, 5% human albumin is a much more safer fluid. If you have to give larger volumes and you have to use in patients who are having sepsis-induced hypertension and HRS, this could be a much safer fluid, which can be used in these patients. Now, coming on to the vasoconstrictors. So after we've done an appropriate volume management, we come on to the diagnosis of HRS, and there is where we start using our vasopressors. Now, what are the vasoconstrictors available? We have terlipressin, we have norepinephrine, and we have octreotide midodrine. Now, all these randomized controlled trials in decompensated cirrhosis have suggested, and including a recent meta-analysis, that terlipressin is as good, the norepinephrine is as good as terlipressin. However, because in US, the terlipressin is not available there, the data is on octreotide and midodrine. However, the European group of investigators had to abandon and stop the trial prematurely because octreotide midodrine in AKI HRS has very inferior, the efficacy is very, very inferior as compared to terlipressin. So when we have choice of all the 3 vasoconstrictors, terlipressin remains the first choice, followed by norepinephrine and octreotide midodrine only if there are contraindications to either of these drugs. Now, how do we administer terlipressin? Again, we can give as bolus, and all the previous randomized controlled trials were using the bolus dosages. But very recently in this randomized controlled trial, they showed that the continuous infusion is much more superior as compared to the bolus doses of terlipressin, and it has a much safer profile. And because this is a costly drug, you also achieve the reversal at a much lower dose that is required as compared to bolus dosages. Now, this is a very recent data on bolus dosages of terlipressin. And again, we have to be very cautious. And what we face as problems routinely is that terlipressin, even though it is very, very effective, the problem is the adverse effects. And this was the data on bolus dosages. And again, here they showed that terlipressin is supposedly having a higher rate of adverse effects and lung complications when given along with 20% albumin for the management of hepatorenal syndrome. And similarly in patients with acute and chronic liver failure, because they have poor cardiac reserve, more often systemic inflammation and infection-driven AKI HRS, here again, in this randomized controlled trial where we compared norepinephrine with continuous infusion of terlipressin, the first important thing that we showed here was, as against the trials done in decompensated patients with cirrhosis, terlipressin continuous infusion was much more superior. as compared to norepinephrine. However, here again, you can see here that the adverse effects are much more frequent in the terlipressin group when given to patients with acute and chronic liver failure requiring discontinuation. And again, these patients become candidates of renal replacement therapy. Now, Dr. Gagan was talking about the biomarkers, and biomarkers is an upcoming area, and we've done a lot of work in this area. Now, this I'm showing you the data of HRS responders versus non-responders, and we did a panel of 17 biomarkers. And we can see here that what predicts non-response is the degree of tubular injury. So maybe we're not diagnosing these patients. They are not HRS, they are actually ATN, because the NGAL levels here was much higher. These patients had more cardiac dysfunction, the NT-proBNP, the troponin T levels was much higher in the patients who were non-responders to terlipressin. And subsequently, we also found that most of these patients who developed adverse events, they also had these high biomarkers, again implying that the degree of tubular injury and the cardiac dysfunction will determine the non-response and the adverse effects to the drug. Now, what target map should we be using? So after we've chosen our drug, we've used terlipressin, we know we can give as a continuous infusion. So what target map should we be keeping? Now, we know that from data of decompensated cirrhosis, if you're managing HRS, your map has to be high. So higher, if you are targeting your map 75 to 80 or even higher, you're improving the systemic vasodilatation, you're improving the venous return, and therefore the renal vasoconstriction. However, when you keep targeting your MAP to 80 to 85 again, and in context of inflammation and infection, this can be detrimental. And we see here, and this is our data of septic shock patients. These were early septic shock where we were targeting. We found that even though the reversal of AKI was better and the tolerance of the dialysis, if you're targeting MAP, the adverse effects are much more frequent if you are using especially terlipressin to target a higher MAP. So what we suggest here from this data is that if you're giving a vasoconstrictor to your patient achieves the MAP which you want to target, please don't keep increasing the dosages of the drug, because this can land up with severe adverse effects. So there are patients who will achieve the response at a dose. And when we see in our practice in the intensive care, we never require more than 3 to 4 mg of terlipressin in our set of Indian patients or Asian patients, and we never go up to 12 mg dose that has been recommended in different by the different recommendations. Now we go back to our patient, and we can see here this patient had high extravascular lung water. He was already given 1 liter of fluid in the emergency department and subsequently had received in the ICU, and subsequently his acidosis did not improve. His urine output was preserved, and this patient was started on terlipressin at a continuous infusion, considering a diagnosis of HRS AKI in context of inflammation and infection. So now the challenges that we face, we have taken into account the urine output, we have removed the absolute value of serum creatinine to diagnose the HRS early. I showed you importance of the biomarkers, which may be very, very relevant. And we have to again manage the HRS differently, in especially the high-risk groups, that is ACLF, refractory ascites, and critically ill patients with cirrhosis. And Dr. Gagan had very nicely shown you all these indices which are used for making a differential diagnosis of acute tubular necrosis. So in a patient with septic shock, you would like to rule out acute tubular necrosis, and the most reliable parameter, all this urine sodium may not be very reliable, it's the urine microscopy and the presence of this active sediment or granular class, because HRS or the patients with pre-renal AKI will have bland sediment, while the ATN patients will have granular cast. And amongst all the urinary biomarkers, it has been shown that urine IL-18 and lipocalin-2 are the most promising biomarkers that has been studied in this meta-analysis. In our experience in the intensive care unit, we use cystatin C and NGAL, cystatin C as a marker of glomerular function and NGAL as a marker of tubular function. And we've shown that if your NGAL is above 1500 and your cystatin C is about more than 3, this this patient would require a renal replacement therapy, because we know that dialysis is a difficult decision. And these biomarkers, if you're using, these can be very, very reliable in making these tough decisions for these patients. Now, very quickly, I'll just rush on through the management of HRS in context of ACLF. We know that all these factors come into play. And we have no clear guidelines as of now, which can tell us how do we manage such patients, but we are seeing these patients day in and day out. And why we cannot extrapolate the same guidelines, and this is our own paper where we showed that AKI is very, very different in acute on chronic liver failure. These patients have rapid progression. These patients have more structural AKI. They are non-responders to terlipressin. The response is just in 35% of these cases. And if you use a continuous infusion, only up to 40%. So most of these patients will require dialysis. I'll skip these slides. And what is important here is prediction of AKI in these patients. And you can see here, if your patient are deeply jaundiced, your patient is having systemic inflammation, circulatory dysfunction, these patients get predisposed. And coulimic nephropathy is something which we should keep in mind in patients with acute and chronic liver failure. This is the injury due to toxic bile acids and high bilirubin, and occurs in context of systemic inflammation. But the diagnosis requires a kidney biopsy, which we cannot do in these patients. So what do we rely on? And these are beautiful pictures of urine microscopy. And you can see here, this is the patient with ATN, which shows granular cast. This is the HRS patient. And you can see here the bile cast, bilirubin crystals, which are seen in patients with coulimic nephropathy. And this is how we need to differentiate, because what we did here was we took 15 such patients in each group and compared to a group of no AKI, just to show you that how the urine microscopy, so all these patients were diagnosed based on urine microscopy. In dying patients, we confirmed the diagnosis with histopathology. All these patients were deeply jaundiced, had similar level of serum creatinine and bicarbonate, but they had different etiologies. And I'll show you here with the PCA plots that each of these patients, the spectrum is very, very different. This is the no AKI group, and these are all 3 different AKI, and there is a clear difference between each of these AKI in patients with ACLF. And when we evaluated the biomarkers, we found that like the urine NGAL and renin could predict, and we found that a cutoff level of NGAL above 1.1, so almost above 1,000, and a renin above 9.4. And between HRS and the coulimic nephropathy, we found that you can use renin level above 1.34 to discriminate coulimic nephropathy from HRS. Now, we subsequently validated this data also. So this has been validated. So NGAL is very, very relevant, and especially cystatin C in patients with ACLF to diagnose ATN. And I'll show you here the relevance of the coulimic nephropathy. We can see here the HRS patients with ACLF, they have suppressed bile acids, but these are the 2 different structural AKI that we see. The coulimic nephropathy patients have higher bile acids. These are the heat map and the cytokine profile. As compared to ATN, these have a pro-inflammatory cytokine profile, while there's a down regulation in ATN patients. And these are the significant differences that we observed in the histopathology. We found that patients with ATN have distinct histopathology. There was decrease in the markers of mitochondrial biogenesis. You can see here the tunnel assay showing more caspase activity, which was seen in the endothelial cells and the epithelial cells, and failure of mitochondrial function, again signifying defective repair. Now, how this data will be important if you're contemplating a liver transplant. Maybe the coulimic nephropathy patients will improve their AKI despite being on CRRT, while ATN patients, you require a simultaneous liver kidney transplant. So if you have time, I can go about, otherwise I can wind up.
No, you can go for some more time, sure.
So we come back to a patient, and I'll show here this patient was enrolled in the clinical study. So we had all the biomarkers available. So I showed you that the renin less than 1.4 here, NGAL is 678. So this patient is not ATN. The KIM1 was high, osteopontin levels were high. The urine microscopy did not show any granular cast. There was bile cast. some bilirubin crystals. You can see here the microscopy, the urine protein to creatinine ratio, and Dr. Gagan was mentioning about the albumin excretion. So we also do protein to creatinine ratio was much higher in this patient, signifying some form of tubular injury. The spot sodium was 39, and all the markers of systemic inflammation were elevated, including the bile acid levels. So how do we manage these HRS, the HRS patients who are at different end of the spectrum, not ATN, in patients with ACLF? Which artificial liver support modality? We know that Prometheus and Mars were previously studied, but were outdated, even though they improved renal functions. But what we use in our center, and the most promising, the artificial liver support strategy, remains plasma exchange. And this is the data from ARC, where we compared patients who underwent plasma exchange versus the standard medical treatment and Prometheus. And we showed that patients who underwent plasma exchange had a better survival when we compared the subgroup of patients where they were the propensity score matched patients, where the patients were matched for their liver disease severity. And overall cohort, the plasma exchange was not giving a survival benefit because most of these patients were dying with infections and other complications. So it was not a definitive therapy, but an important modality. And this is the data of patients undergoing plasma exchange. For coulimic nephropathy, we see, I showed you the data that coulimic nephropathy is driven by systemic inflammation, bile acids, and this is how plasma exchange can improve coulimic organ dysfunction. Now, it is not just the quantity of bile acids, but also the type of bile acids. So we need to do more research, and this is some of the data metabolomics of patients who underwent plasma exchange, and these are the survivors as compared to the non-survivors. And we can see here that the type of bile acid was also clearly different. So it is not just the number, it is also the type. And plasma exchange, even though it clears all these inflammatory cytokines, it is not that everybody responds. So the responders had an improvement in the mitochondrial function. And I told you, coulimic nephropathy patients have preserved mitochondrial function, and the monocyte phagocytic function improved after plasma exchange in responders, but the non-responders, despite improvement in all the pro-inflammatory cytokines, had succumbed to infections. When we compare the two phenotypes of structural AKI, we see here a clear difference. So I'm showing you the data of endotoxin. In patients with ATN, there is a significant increase in LPS levels, while in coulimic nephropathy patients, there was decrease. So some worsening usually happens in ATN if you do plasma exchange, because you're removing the protective cytokines from these patients. The endothelial dysfunction markers, NOS and the ferritin, even though reduced in both, there was a significant reduction in coulimic. So this is how we imply this knowledge of diagnosing these renal dysfunction patients. In our patient, we did low volume plasma exchange on day 1. And these are the parameters I showed you, because this patient was having a very high INR. After giving appropriate antibiotics, fluid management, improving the hemodynamics, starting terlipressin, we gave this patient, we did a session of plasma exchange. And these are the parameters pre and post plasma exchange. And there was a significant reduction in inflammation, some improvement in the markers of inflammation can be seen here, but the shock did not improve. And so this patient also had these complications. This patient already had pneumonia, and this is what we see. Even though we did a very low volume plasma exchange, we saw this patient had pulmonary infiltrates. So therefore, there remains also to consider dialysis. And what we do in patients with acute and chronic liver failure is to go with CRRT, because that's a more safer modality. It preserves the renal function. But it is not that, again, like I showed you for plasma exchange, there is not that everybody will respond to these therapies. Some patients may even get worsened, which we say as the non-responders. And we can see here that non-responders were the ones who were most severely who had more severe liver disease, higher MEL score, higher SOFA score, and most of our responders had received a combination of plasma exchange and CRRT. And we can see here the difference between responders and non-responders. The non-responders had worsened after CRRT. NGAL levels had shown a worsening trend. We can see here the responders had shown improvement in all the parameters, the improvement in ammonia, the heart rate, systemic hemodynamics, lactate, but there was no response in the non-responders. And non-responders also had worsening of coagulation. And this is a very difficult complication that we see in these patients, and these patients had bleeding events. So what we feel is that and when we did the analysis in these 30 patients, we found that if you're doing the CRRT timely, so this patient was non-oliguric, had some acidosis, did not meet absolute value of serum creat, absolute criteria for dialysis, but we initiated CRRT early. And similarly, we found in these 30 patients that in the responders, the earlier the initiation of CRRT was considered after the initiation of shock, we found that the chances of recovery and improvement was higher. And we found that each hour delay in CRRT in patients who were in septic shock and ACLF was associated with a 7% decreased chances of renal recovery. So in this particular patient, we started him on CRRT after doing the plasma exchange. And we can see here the course of parameters. By day 4, his norepinephrine had tapered off. He had improvement in all the parameters. There was an improvement in NGAL and all the renal biomarkers. Osteopontin had shown an improvement. The urine PCR had shown an improvement, and so was the shock, had improved at 48 hours. The AKI resolved. So this is a responder for us, because we were able to optimize this patient for a liver transplant. However, subsequently, this patient had succumbed after day 15 of ICU stay in the absence of a living donor. These are the microscopic pictures of urine analysis, and we see the disappearance of the bile cast here. And there was an improvement in all the hemodynamic parameters. So I chose this case just to show you that we optimized this patient for transplant. We could not achieve a complete survival at 28 days because the transplant remains the definitive option. And this is my last slide of the algorithm that I would suggest we should follow for managing patients with HRS AKI. First is to rule out underlying chronic kidney disease, give an appropriate volume expansion, rule out all the offending agents, see for AKI progression or persistence. In the ICU, use the urine output criteria. If your patient is volume unresponsive, look for a urine microscopy, use biomarkers. If at all you are using at your center, initiate vasoconstrictors, norepinephrine or terlipressin in decompensated cirrhosis, ACLF preferable in patients, in terlipressin preferable in ACLF patient. If your patient is having all these, an abnormal urine microscopy, rule out intrinsic kidney causes. And in coulimic nephropathy, again, I showed you some data, but there is no guidelines and no recommendations, but this is what we feel, that it is driven by systemic inflammation. So anti-inflammatory strategies and maybe plasma exchange and CRRT could be helpful for managing these patients. Thank you.
Right. Thank you, Rakhi. That was very good, and I think an elaborate talk, and I would really appreciate for all the insight you have shared. We'll have some, I think, question and answers which I have been receiving, and I'll straightway start with Dr. Gagan. Coming to very basics, I mean, if somebody, because we have these, students who would like to know if somebody with known cirrhosis, ascites comes to the casualty and he's got a renal shutdown, right? So, and somebody who's there, and so how would you approach that patient? What guidance will you give to the, a casualty doctor, what he should do? Somebody's got renal shutdown, has got cirrhosis, and has been in the triage.
So, as has been elaborately discussed in detail, both the talks. So, my take on it is, if you have a good history, you can make the diagnosis around 75%. The rest is just to help you. If you take a more critical decisions, especially a patient coming in casualty, the most important will be the history and the clinical examination. If you take a history, what precipitated the renal failure, you will find most of the times you have patient taking some type of an NSAID painkiller, some type of a diuretic misuse, overuse, some type of a poor intake leading to dehydration. All these things can be easily ruled out, and prerenal causes can be taken care of immediately. Then if you take a good history, you will come to know what is the baseline creatinine. Now, baseline creatinine is one of the most important things, and I consider baseline as a value within the last 2 to 3 months, which is the lowest possible value that you have. And if you have that value, you immediately come to know that what you are looking at exactly. Is it an acute kidney injury or a chronic kidney disease? Okay. Once you differentiate between the acute and a chronic kidney disease, then you know the reversibility and the prognostication of that, right? Then is the most important next step will be the pressures, blood pressures, and the examination of the urine. If you have a urine which is totally normal, totally bland, no significant albuminuria, no significant cast and other findings, no significant sediments there, then you are probably dealing with the liver cause for the renal dysfunction. But if you have a urine examination which is showing proteinuria, if you have a urine history which is showing a diabetes, we have a history which a creatinine is already 1.5 baseline for last few months or years, then you are probably looking at some intrinsic renal disease. You're not looking into something called hepatorenal syndrome, especially not at all with the prerenal type of a setup. So diagnosis 75% is made with this. Rest, then will depend upon the management as we have discussed, whether we give the fluids, see the response, but definitely those things comes afterwards. The more important will be the urinary finding, a good clinical history, as well as clinical examination. That's my take on it. Especially the other complex things like urinary markers and all those come later once you are taking more important decisions when the patient is admitted. But as far as your question is concerned in the casualty, I think this thing should sort out the matter.
Right. I think that's absolutely right. I mean, you have really put the right, perspective into it. Rakhi, like if you have this patient, in the casualty, and you have to decide about, I mean, again, a person who's in the casualty and the CMO about, giving a, fluid challenge, giving, albumin. So, what guidance would you give to this doctor?
Yeah, so what we teach our residents is like taking a good history. So if the patient is volume contracted with a patient who's decompensated cirrhotic, has been overdosed with diuretics, such patients will be the peripheries and there will be no peripheral edema. The patient will show signs of severe hypovolemia, peripheries are dull, the patient may have shock or may not have low hypertension. And then you can give a volume challenge and see the response. If the patient is fluid responsive, there will be an improvement in MAP, and you will have some improvement. If you're doing a blood gas, you can see improvement in other parameters. So that is what, sir, we suggest. If we are catheterizing a patient, then we suggest monitoring for the urine output. And catheterization routinely we do not do unless the patient is requiring is in shock or has more complex hemodynamic problems. So, and if the patient on the same end is decompensated cirrhotic who has history of diuretics but has florid signs of capillary leak, has peripheral edema, anasaka. So such patients, a volume challenge should not be given. It has to be more guided. And here is where we have to think of infection or inflammation driven AKI. These patients may be already in the volume overloaded side, and there, if you start pumping fluids, you may harm them in an anuric patient. So there it becomes very important that we don't immediately rush on to fluids in such patients.
Right. And between 5% albumin and 20%, 25% albumin, do you have a advice, preference, a choice?
Yes, sir. So in our ICU, sir, we are not at all using 20% albumin. Only in few cases, I can just say that in few cases of hepatic hydrothoraces or refractory ascites patients and not in shock. So such patients, we use 20% albumin, but most of our patients, we go with 5% albumin if they are in shock and hemodynamic problems or for AKI management, because we see and we have a vast experience that it is more well tolerated. When we have to use patients who are on CRRT, dialysis, and we have to give we are now using 25% albumin in that group of patients where we don't want to give too much of volume, but we want to replace some albumin. So we use 25% albumin, sir.
Yeah, I think that's very right. And I mean, any of you, like we do discuss MAP, in these patients. In fact, that's an important aspect. So what is, the like MAP thing, which you did mention low MAP versus high MAP and how they respond. Again, in the management perspective for a resident, what is the aim they should look at in renal failure in cirrhotics?
So in a cirrhotic with renal failure, what I would suggest is if the patient is having septic shock and the patient is volume contracted, we should not target a very high MAPs. Means we should not aim for MAP. We should rather aim for volume, and maybe a lower target around 65 to 70 is better. But if our patient is on the hypervolemic end, has HRS, is in third space, there a better is to target a higher MAP, because higher we are able to counteract the systemic vasodilatation, the better is the outcome when it concerns the kidneys. So there we should try, but obviously if you're using terlipressin for maintaining that level of MAP, I would recommend, I have given a checklist in the ICU that you have to check on terlipressin every 4 hours for all the possible peripheries, adverse effects, because the adverse effects are detrimental of this drug. So we have to be very, very careful while we are giving our patients terlipressin.
Correct. I have a question
I
from
can
Dr.
add
Yeah,
to a
yeah,
point
Gagan,
here,
please. Please carry on, Gagan. Yeah.
Dr. Rakhi, I think a urine output measurement at this point will be very good, very easy criteria to see how much of MAP you can target. If you're having a good urine, clinically, I think even a lower MAP, you are having a good urine. So I don't feel a point to target a higher MAP, and you can probably save on side effects of the terlipressin. So maybe that simple criteria, because these patients are catheterized and in the ICU most of the times in which we are targeting these things. So maybe a very good indices in this specific group of patients, as well as the clinical indices is concerned.
Absolutely.
That may be.
We have this, I think Dr. Prakhar Garg has asked this question, how to differentiate between HRS, AKI and ATN in clinical practice. Gagan, you have already spoken a brief, clinical tips on this.
Can you just repeat, sir? Sorry, I missed the HRS.
Dr. Prakhar has asked how to differentiate between HRS, AKI and ATN in clinical practice.
Okay, so Dr. Prakhar, the point is that HRS, AKI and ATN, the differentiation will start right from the word go, you start the history. Okay, if you see a patient of a chronic liver disease and you see that the patient creatinine baseline is normal a few weeks back, then you are probably looking into a factor that he has an acute kidney injury. Now, if he has an acute kidney injury, you look into two factors. What are the possible causes of his getting into that acute kidney injury? Now, one possible cause is you find the patient having an infection going on underlying, some type of a use of NSAID, some type of overuse of diuretic, and some type of other, secondary effect which is going on. If you see that all those findings are not there in the clinical history, there is nothing we could use that of all these. Then you look into the third aspect of it, that further go urinary indices. You try and see if the patient, how is the urine output of that patient, what are the urinary indices of that patient, urinary spot sodium can be taken help of, urinary markers, sediments, active sediments can be taken help of. And then further moving, after that, you can also go into clinical aspect and give a trial of, that Dr. Rakhi has just said, the trial of albumin, the trial of fluid, to see whether it responds to that or doesn't respond to that. Now, the point here, the problem is there can be overlap sitting inside. There can be a patient which will having just, that's the case, complicated case that Dr. Rakhi had showed. If I would have not looked into the NGAL and all those stuff, high tech stuff, which was available with Dr. Rakhi, luckily. So that I would have probably looked into two aspects into that. A patient having an ATN with a sepsis underlying in it and associated HRS, probably because it didn't get corrected and, you gave all the treatment for HRS and he improved. So from my side, that was two things going on simultaneously, which I had discussed, ATN as well as a probably hepatorenal syndrome with an AKI. So right. These are the only way I can see. That's definitely the last point is the markers, that if they are very good to help you and will help you in the clinical diagnosis of that patient. Yeah. If you have those markers available with you and you know how to interpret them correctly, that's also very important.
I think the same thing, I think Dr. Rohit has asked about this. Rakhi, maybe you can take this up. Does a continuum exist in HRS and ATN? And is there a way we can differentiate ATN, which is preceded by HRS, and ATN due to other causes?
I think so. This is the question of research, and that's why I showed in my algorithm, there is a group where we cannot say that these patients are HRS or these patients are ATN. We have a mixed group, and I feel that cholemic nephropathy, like I showed you, I believe it's a mixed group because it has some components of structural, it has some component of HRS. So this is a beautiful example of this, where you have a mixture of both HRS and ATN, kind of tubular and functional insults going on. And how HRS can progress to ATN, this itself is a research question. We see many patients who had HRS and then they progress to ATN. So that's a separate group of patients. But when we are talking broadly is HRS and ATN. So because HRS patients will respond to the vasoconstrictors while ATN will not.
Yeah, I think this is an important aspect, and I'm not bringing transplant today actually at all, but I know that there are many patients who are actually considered as ATN and have done a transplant. They've actually recovered very well. So I don't think we should. That's a very again a separate discussion altogether, but it's an important point, and we are really closing now actually as the time is running out. So Rakhi, one like a prescription from you for a patient who is in ICU. Can you just tell me what is your prescription? What do you write in the chart 1, 2, 3, 4, 5 for that sick patient, liver failure with renal failure? So what is your prescription which a resident can follow?
So my first thing is I feel all these patients are so hypovolemia has to be looked into. So my first prescription will be rule out signs. If we have ruled out the patient is not in volume overload, to give an appropriate volume management. I keep the target map, like sir was saying, I would like to keep a target map around 70 to 75. We don't target too high map. Norepinephrine is my first choice vasopressor. We do not start with terlipressin for all patients, even though we may be dealing with an HRS. Appropriate ruling out infection and appropriate management of infection is the utmost thing. And then targeting, I would rely more on, I don't know, there are no guidelines, sir, but I feel blood gas parameters, acidosis, the level of sodium, chloride, all these are very, very important in managing AKI. And subsequently, I will target the urine output to understand my AKI is getting better or not, and then decide on whether we have done an appropriate volume management. We go with terlipressin. My blood gas parameters are still not showing improvement. This is where we start contemplating an RRT. Urine microscopy is the most important thing, and we do routinely urine microscopy. Urine spot sodium may not be very reliable, but yes, at times where we are having these difficult scenarios of HRS versus ATN, we go by this. We send urine NGAL and cystatin C, but we don't get a timely report. We subsequently get it. So that is something like we should be having these bedside biomarkers available, which can ease a lot of things for us as clinicians in management.
Excellent. Any last minute advice, Gagan, to the residents?
Sir, I don't know, but I believe that as a resident, my first and only thing should be a good history, because that's where we are lacking nowadays. But I have personally seen a good history will give an exam with a good clinical examination, gives a diagnosis 75% of times. We do it in our OPDs daily, and I do believe that will help. The other parameters like urine, and especially the highly specific test, maybe an ultrasound is good enough, and a simple urine test that will clinch it around 90% of the time. Rest will be then other things like the way the patient responds to the therapy and other things. For a resident, it will be a history, clinical examination plus a urine test if you can do bedside or maybe with the help of a lab.
Absolutely right. I think this is a topic which you can go on discussing for a number of hours, and you can still have something coming out of it. And I think it's very useful discussion. I myself highly interested in this topic, and I in my rounds with Gagan is with me all the time. We keep on discussing again and again, and now with transplant, maybe this is really not that forum, but one of these days we'll have transplant and liver dysfunction, and that will be a separate discussion altogether. With this, I think it was a very useful discussion. Dr. Vanita, would you like to add anything before we close?
Thank you, sir. Thank you, Dr. Rakhi and Dr. Gagan for being here for this session. I think it's extremely informative for the residents as well. I learned a lot of things, refreshed my knowledge also. So thank you all very much, and we hope to have the next session soon. Just for the participants, the recording will be shared with you shortly on your email IDs as soon as it is available. And please feel free to contact us for any questions you have, and we will be back with the next session as soon as Dr. Saigal is ready with it. Thank you all
Yeah,
very much.
right. So the next session is going to be in about 3 weeks from now, and we're going to discuss about infection, liver, which we see in patients who come to the casualty with liver problems. It's going to be very exciting, I'm sure. And also, I've seen that Dr. Vanita is now actually also giving beautiful certificates for the attendees, and I think that's very interesting. And continue to post your questions, which we are answering on the chat box even after sessions are over. So thank you everybody for joining, and Rakhi and Dr. Gagan, wonderful. It was nice having you here
Thanks
today.
a lot.
Thank you very much.
Thank
Good
you,
night.
Dr. Rakhi.
Good night all.
Okay,
It's a pleasure.
bye-bye. Good night.
Yeah.